previous few days. That's not what's the normal urine that's happening now. So if you look at the urine and it's favorable, then you can talk about doing something therapeutic. So basically, again, 3 urine samples. Then what we do is we put a catheter in and try to drain the bladder and provide fluid from around the baby. Okay? What you do is it's called a rocket catheter. You take a rather large 18 to 14 gauge catheter, give mom sedation, make an incision, put that down through the uterus, and you put that into the baby's bladder. What you do is just like this, and it's a double pigtail. I think you can see it up there. And the reason it's a double pigtail is, believe it or not, these will fall out or they will pull it out. The baby will pull it out. So double pigtail, so you can drain the bladder, get fluid around the baby, and get the lungs to develop. And it's just like that. You guide it under ultrasound into the bladder. Sometimes you have to paralyze the baby if they're moving a lot. Sometimes just sedating moms will do it enough for you. But obviously, somebody putting a trocar in your bladder would not make you happy, right? We talked a little bit about Isoimmune Fetalis, okay? And this is Dr. Liley. It was 43 per 1,000. What's very interesting is you look at ethnicities, it varies. I was in Spain this last month, and I was in the Basque country up by Pamplona, and of course I asked the medical students, I said, do you know what the percentage of RH is in the Basque country? And of course they're not all from there. They're from different parts of Spain. They still didn't know. What are they teaching them, right? 85% of the people in the Basque country are Rh negative versus about 10 or 15% overall in the normal population, is less than 1 or 2% in certain other ones. So basically, if you look at this, what happens is the first pregnancy is okay, right? You bleed and then you sensitize is what used to happen. So what happens was you get severe hemolytic disease, you destroy your red cells, the baby gets anemic, goes into heart failure, and dies. That's basically the simplistic view, a little more complicated than that, but that's sort of really what happens. So the critical titers we used to do when we checked moms is 1 to 8 to 1 to 32, and you're supposed to check that. Less than 1 to 8, you don't have to worry for Rh disease. You need a 4-fold rise on a monthly basis, and you can also now test for, in the maternal blood, you can actually do Rh sensitization testing for Rh factor in the maternal blood, looking at cell-free DNA, in theory, and find out if that baby's Rh negative. The other thing you could do is ask the father to get his blood type tested, right? Well, unfortunately, people don't always tell you the truth, right? I know you find that hard to believe. But that might not really be the dad. I'm just saying, maybe, right? And of course, if the dad's sitting there and the mom's there, she's not going to say, oh yeah, that's not your child, right? That's not going to happen. But non-parental, is not uncommon. So looking at cell-free DNA is supposedly about 100%, although nothing to me in the world is 100% except death and taxes. I always tell people I don't believe anything's 100%. I don't care what the study says. It's usually just they haven't tested enough or not telling you the truth, right? So these babies got scalp edema and they die from basically high output heart failure. So we used to do these amniocentesis, and it used to start at about 18 weeks. Every week, the woman would come in and have to put a needle in her abdomen and draw fluid, which of course made you very popular, right? Nothing would make anybody happier than, oh, I get to go see Dr. Calhoun again. He gets to stick me with the needle again, right? And then you'd have to go get that run, and you'd find out these curves and find out what the risk was, and you did all this stuff you would used to do. Now, thank goodness, we now just do Dopplers. We get the ultrasound, we get the baby's head, we look for the middle cerebral artery, and the reason we do that is that's the only one you can get a vertical or an absolute vertical look at. Now, why is that important? Well, if you're my medical students and my residents, I say, why is that important? They go, I don't know. I said, well, what's the cosine of 90 degrees? It's 1. That means you can do a velocity. If you don't know the angle, you can't do a velocity. So that's why we use that artery, because that's the only one I can do an actual 90-degree look at it. And then we look at these different velocities that we've charted out, and as long as they're okay, we don't have to worry about it. We can do then transfusions. We can use this Doppler data. We go ahead and transfuse the babies, and we can do that every 2 to 3 weeks until we get them to 35 to 37 weeks, and then you just deliver the baby usually, right? Again, this is the umbilical vein. You're putting the cord. You can see that needle point going into that vein there, and you can see you're going to infuse that. Infectious Hydrops Fetalis is very similar. It's parvo B19, which is also called slap cheeks disease. Everybody almost always gets it when they go to school. It's very, very infectious, so everybody almost always gets it. If you look at that, this is toxoplasmosis and parvo. Toxo is a very, very different. And of course, most people have already been exposed to that as well, particularly if you're from France. And why is that? They eat raw hamburger, the steak tartare. Yeah. And the cysts are in the raw meat because, of course, the cats, pass the cysts. The cows eat the grass with the cysts, or the mice have it actually, and then you can get the cysts in the steak tartare, and then you get toxo. All right. So the transmission rate increases as you go farther along. And again, you can see this baby with pleural effusions. There's fluid around this chest and up around the heart that's not supposed to be, and this kid's infected with toxoplasmosis. So you can use acute titers and you can use chronic titers. If you have a chronic titer, you're already immune, you don't have to worry about it. But some people believe that it's hard to tell because you can be in transition between whether you're acutely affected and also affected. The real issue, of course, is the fact, and not just the fact that you get hydrops, but this can cause calcifications in your brains from the toxo and also liver calcifications. The big one is obviously cerebral effects, which can be significant in these babies. And you can also do now amniocentesis, and you can do DNA and look at toxoplasmosis in the amniotic fluid if you really want to know. Treatment can be done with antibiotics for this, and there's been at least one case successfully. I've treated 1 or 2 cases of toxoplasmosis. Both of them seem to be successful. The babies were not affected, but it's sometimes very difficult to tell until children get a lot farther in school. Parvo B19 is the other one we talked about. It's very, very common because of the viral transmission, but it's very low in its fatality rate or its effects because it basically causes a different way. It really just suppresses bone marrow. So that kids get anemic and go into high output failure. Very similar. That's what we talked about. Again, different ways you can do cordocentesis. You can do it in the basement here, which is the best way to do it because that's the easiest because the cord's stable. Going it laterally is much more difficult, and posterior is very, very difficult because you have to get by the child and the baby and get down in the cord insertion. I find that to be virtually impossible because the kid's moving all over the place and it's just very difficult to get to that. We talked about IgM, acute infection. We also talked about the Dopplers, and we also talked that if you treat these kids, they do much better than if you don't treat them, particularly if they're hydropic. You just transfuse them and help them get through that. Quick pause, and we're going to talk about what's called a congenital diaphragmatic hernia. Has anybody heard of that? Congenital diaphragmatic? Yeah. Not all that common, but I see it probably once or twice a year, depending on which group of patients that I see. Of course, because it's a structural defect, males and females are affected basically equally. Right. So left-sided is most common side because the liver's on the right. It tends to block this. The right side's uncommon. And bilateral is very, very rare. You only see that once or twice in your career probably. We know that it's just a structural defect if closing of your diaphragm doesn't happen. And so what you see is, hopefully, there you go, you shouldn't see the stomach and the heart together, right? The stomach's supposed to be down in your peritoneum, down in your lower part of your abdomen, and your heart's supposed to be in your chest. And again, if you're a first or second resident, you see that. It's pretty easy to diagnose. This is not a complicated diagnosis, right? Well, the mortality in next selected case is very high because, of course, they deliver someplace where they're not supposed to. There's no prenatal care. They don't get transported, and they're okay initially, and then they go into respiratory distress, and then they don't do well. Prognosis, obviously, of course, this is not sophisticated. Bigger. If you diagnose it way earlier, it means it's bigger and worse. If your liver is above your diaphragm, that's really a bad thing, right? Liver survival, if you put babies on extracorporeal, is very high. If it's below the diaphragm, above not. If you have a lung that's very small, of course, that makes sense because you don't have any lungs. And if you have other associated cardiac or other anomalies, which can be with this as well, or bilateral. There's been several different ways of treating this. One was called a tracheal clip. What we would do is we'd go in, not myself, but the surgeons would go in, they would make an incision with a scope. We'd go in with a scope, make an incision, and put a clip on the trachea. Okay, that doesn't sound very good, does it? Well, what are you going to do now, smart guy? Yeah. So the reason that helps is that your lungs are actually a part of the majority of the fluid that's actually in the amniotic fluid. Tremendous amounts of fluid are created by the lungs as it goes into the amniotic. They swallow it back, and the hydrostatic pressure is what gets your lungs. If you block that, you actually get the lungs to grow and develop, and as that hernia is there, the lungs grow and they push that hernia down gradually. So it doesn't kink anything, and it actually does inflate the lungs with the fluid and pushes that hernia down by itself. And this is them, just a picture of them trying to put this clip on the trachea here. Now, unfortunately, that creates a bit of a conundrum when you're born, right? Because now your trachea is blocked. So what we do now with that is called an extrauterine exit procedure, where you actually go in and you do a tracheostomy, intubate the child, and then go in and you take the clip off. Well, that seems a little bit aggressive, doesn't it? So now there's another trial going on, and they're still going on both in Europe and the United States, where it seems smarter if you just take a balloon, right? You put a balloon down in there, and you blow the balloon up, and then leave that. And then when you take the baby out, you just deflate the balloon, because then you don't have to do any surgery, right? You can just deflate the balloon. And that seems to be an improvement in what we had previously. So that seems to work for particularly the ones that are on the right side or that are a little bit larger, and you're trying to get that to gradually go, because if you try to repair it in utero or you try to repair it afterwards, you can kink the hepatic veins, and there's just a lot of stuff goes on that doesn't go very well. A cystic adenomatoid malformation is very similar to just a cyst in your lung, okay? Usually unilateral, but can be on both sides. And it's very sophisticated how you do this. It's called big cyst, little cyst, and medium cyst, right? Yeah. Doctors are very clever that way. We are able to do these things, as you see. Yeah. So most of them are macrocystic, one cyst or two cysts in the lungs. And again, you see the larger cysts, which is what I usually see, the big ones over here. You see sort of the medium size, and you see the very bright, lots of small cystic areas. They can appear solid or mixed. Usually I see them quite early. And what's really interesting about these, if you just leave them alone, they just go away. As the lung grows, it compresses that abnormal tissue. You don't have to do anything. If you see them very early and the baby starts showing signs of failure, that's a very bad thing. Also, if you see the midline of the trachea going to one side or the other, that's also bad, because that means that it's growing or it's rather large. This is what it looks like. This is the heart over here, and this is all this very large cystic adenomatoid, and this is the normal lung on this side, right? This is the left side. This is the right, huge, huge cystic, pushing the heart over and pushing the lung over. This is a very, very large one. And this kid's already starting to show some signs of failure. So this would probably need to be resected in utero. Again, if you have a big enough cyst and it's large, you can do what we did with that bladder, right? You got to make a small incision in the abdominal wall, take that catheter in, put it between the ribs, and drain that cyst and let everything go like it's supposed to. Again, you've got a large amount of ascites, this huge, very bright, large cystic adenomatoid malformation. Now we're going to go to neural tube defects, which are really interesting to me. I find them probably the most fascinating for two reasons. When I started doing this many years ago, which is many more years older than my children are, some of them, we really didn't have a good way to talk about preventing or treating neural tube defect recurrences. And what happened at that time was a very intelligent individual said, well, what if this is related to vitamin supplementation, right? What if it's related to something that goes on? And he knew that folic acid was critically important to all development and all cellular development. He said, well, what if we just treat people with folic acid? And of course, everybody said that can't happen. That's just poo-pooed at all. No, that can't happen. Well, lo and behold, if you treat with folic acid, you can decrease the risk of recurrence by about 50 to 75%. And you can prevent the occurrence of it by just a milligram or so every day in the normal population, which is why now all breads and everything are all folic acid supplemented to decrease the incidence by 40 to 50 to 60% in the normal population. Otherwise, you have to eat spinach like Popeye, and nobody will do it. So, yeah. Especially in West Virginia, trust me. They're like Tim Hortons eating biscuits and gravy, trust me. Yeah, true. So neural tube defects are really not 1 in 1,000 anymore. They're probably like more 1 in 500. We've really decreased this incidence significantly. It is related to folate deficiency, and we've increased it by about 50% with just 400 micrograms, although now it's probably a milligram total per day. And you need 4 milligrams if you've had anybody in your family, child, sister, brother, or yourself who's had a history of a neural tube defect. You can diagnose it by elevated of the maternal alpha-fetoprotein, which is a protein that crosses across that membrane when it's open, or you can see some things on ultrasound, a dilated posterior portion of the brain. You see the collapse of the frontal portion of the head, or you see the open neural tube defect. Anencephaly is lethal because there's no cerebrum, and those babies all die within a few days to hours usually. Some, they're covered with skin, will live longer because that's not really anencephaly, that's really acrania. And spina bifida, the open neural tube defects are variable. There was a study done by this in the United States. It was called the MOM study. And they looked at, they were going to do 200 patients in each arm of this thing. And they did it based on the level of the lesions, and they did it gestational ages, as you see, 19 to about 25 or 26. You had to be 18 so you could give consent, and you couldn't be overly obese, you couldn't have other things going on. The trial stopped actually in 2010 out of 183 of the 200 patients they wanted to do, and they did an interim analysis, which is what you should do. What they did is they had 78 with prenatal surgery and 80 who they did surgery afterwards, and they were all matched for age and gestational age and all the things they could match with moms as much as possible. The two outcomes were really most interesting. One was the shunting and the mental and motor function. What they found was they decreased the risk for shunting pre-surgery to only 40% versus 80% postpartum. So if you had the neural tube repaired, your risk of a shunt was only 40%. If you had it after, your risk of shunt was 82%. What they found was they had both a composite score for the mental and motor compared to postnatal, and they also did a secondary analysis for ambulation. What they found was really, really stunning, actually, was that ambulation without orthotics was double what it was if you operated on children after they had delivered. Now, they did have an increased risk for preterm delivery. Obviously, you operate on the uterus and you're doing uterine repairs, you have a lot more preterm deliveries. So now, in my country, this is the standard of care, is to offer people repair of neural tube defects, which were thought to be basically, you couldn't repair them, you couldn't do anything with them, and you had all these issues with them. You can decrease the morbidity significantly to the baby in particular if you do the surgeries in utero now. And that's actually standard of care now. Sacrococcygeal teratoma, very rare. It's a vascular tumor that's down in the posterior portion of the spine, down by your sacrum, as it kind of sounds like, and they're usually well encapsulated. Very high mortality rate because these are very high vascular tumors, right? And they also produce a mirror syndrome in mom or preeclampsia. So basically, if you look at them, they're very vascular. They have a very high output. And you can tell that by looking at the Dopplers, and you can see this rather large cystic area here, and this is the tumor here, very, very large. This is the baby here, and you can see how huge this thing is, probably 8 or 10 centimeters. It's as big as the baby's head. And this is by MRI. You can see how, if you do the MRI, how really large these things, and you can actually delineate that there's a nice capsule around it, and you can see that that's well subscribed. So I've seen them as early as 14 or 16 weeks. You can see them solid, you can see them vascular, you can see them cystic, and you look at all the other things you think they might be. So you have to monitor these babies and check them and see if sometimes people think you can ablate them, sometimes you can't. Not very big numbers, but this is that same type of baby. This is at about 28 weeks. Here we see the baby here. We see them. This is the sacrococcygeal teratoma, which is almost as big as this baby is. And what they do is they basically will cauterize and shell this out, and then tuck the baby back in there, because it's on bypass right here, and then let the baby develop normally after that. This is actually very successful if these kids are really ill. And this is, again, what's that? About 28 weeks. Yeah, this baby's about 28 weeks. Right at, yeah. And this is how big this, and the reason they did this is because this kid was starting to show signs of failure. The next one we're going to talk about briefly, this is the bubble kids. Anybody heard of the bubble babies, the bubble kids? Yeah. It's called SCIDS, or severe combined immunodeficiency. It's an X-linked autosomal recessive, blah, 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 right? But it has both T cell and B cell. So their death is by infection, correct? Well, it's interesting. We've tried lots of stuff looking at doing transplantation, looking at stem cells. The problem you have is that you become immunocompetent by about 14 weeks. So every time you try to do a graft or create a baby with some sort of a stem cell, they reject it and they die, except if you don't have any immune system. So what you can do is take mothers' T cells and B cells, if you would like, actually stem cells, and put them in the baby through the cord, and they will implant. So you do this at about 18 or 20 weeks, so the baby's born as it was called a chimera, 2 different kinds of genetic material from mom and baby, and these babies now are immune competent, and they don't have this problem anymore because they're now immune competent, right? Because they have mom's T cells and B cells. So they just engraft it, and they're healed by that. Twin-twin transfusion. Anybody heard about this? Yeah. This is actually not that uncommon, actually, and I see this probably several times a year. 1 placenta, right? Two sacs, 1 placenta. You can't have 2 placentas generally and have this happen because the vascularity is separate, correct? So growth off by about 50%. Lots of fluid in one baby and not much on another baby, right? Polyhydramnios, oligohydramnios. And really, really different hematocrits at birth, but that's too late to do this, right? We think it's probably shunting. In other words, when you have a placenta grow together, some of the arteries and the veins kind of cross over and they create a shunt or some sort of a way in which those communicate. One of the babies who's in the arterial side has high output failure to the baby who's low output or low volume, and so the little tiny baby is pumping like crazy, and the big baby gets all full of basically blood and has lots of fluid, and the little baby's small and starving because its placenta is not getting perfused properly. So very, very, very difficult situation, and this can happen very early, like at 16, 18, 20 weeks. Again, really low fluid, high fluid, unequal placental sharing. So if you have late onset growth differences, not a problem. Late onset hydramnios, not a problem. No hydrops, no big placenta, no cardiac failure. And we look at the heart too, make sure there's not failure there. Unfavorable early onset, obviously, lots of fluid, baby and failure, cardiac issues, right? So sometimes people do chromosomes, although generally if they're normal, most of us don't do that because you have to do 2 amnios, and just because you increase risk for preterm delivery, nobody likes that. And we do all the other anatomy, right? And we look at, see if we can see these vascular anomalies. Sometimes we can document them on Doppler. So we used to do reductions, take the baby had more fluid and try to reduce it. Well, that didn't work very well. Then somebody got the bright idea, well, let's just put a window between them so they can do their fluid. Well, guess what happens? The cords go through, right? And then they twist up and the babies die. Yeah, bad idea. One of those ideas you think, wow, wouldn't that be a great idea? Let's build an Edsel. No, that's not going to work. One of my colleagues developed what he said, well, wait a minute. If it's actually a vascular malformation, what if we just fix the vascular malformation? And he started this with did animal work on it, and then he finally started doing fetal work on it. And lo and behold, he would go in with basically a laparoscope or a fetoscope, and he goes in with a laser, and he just basically ablates those vessels that he can see on the ultrasound and video, and just ablates them and lets them equilibrate, and it actually does work. And the survivability is much improved, and the survivability intact is much improved. In fact, the treatment of choice now for this, if it's severe, is laparoscopic ablation of these vessels. So again, something that couldn't be treated, now we can treat and get good outcomes with. Fetal arrhythmias, see that not infrequently, not a lot. I mean, there's just, babies' hearts tend to not have a whole lot of that stuff going on unless there's a big heart defect. Tachyarrhythmias, sometimes we'll see those. We'll treat with them with medications and can sometimes do that. We have multiple medications we can use. We can actually use one medication if, anybody familiar with supraventricular tachycardia or SVT? Yeah, they laugh. Too much caffeine? Yeah. So you can actually treat that in utero with adenosine just like you can an adult. Inject the cord, heart stops for about 6 seconds. And of course I tell people that's the longest 6 seconds of your life, right? You keep thinking, you're counting it down and hoping it's going to come back, and lo and behold it does. So it does work in babies too. Bradyarrhythmias usually are chronic and structural defects. There's not a lot you can do about that. You really can't put a pacer in there. People sort of thought about that, but it doesn't really work that well. And usually it doesn't affect the babies growth-wise. They just have to be paced when they get out. So when they get out, you have to put a pacer on them. This is a very bad one. Anybody heard of hypoplastic left or hypoplastic right? Yeah, this is a real bad actor. We think it's usually aortic or mitral valve is small or absent. It can be in some cases an autosomal recessive and inherited in families with the 2 parents. Recurrence risk with one is about 4%, 2 children up to 25% if you have one baby then a second baby. Very high recurrence risk. And what you see is the left side of the heart, because of either the mitral or the aortic valve, which is in the back there, are either smaller or not there, right? So you got a small left ventricle is smaller here than the right. It should be the same size. And you've got a small mitral valve, actually. And you can see the really, really high flow. If you look at this, the Doppler flow is very, very high here. It's in the 2 and 3 and 4 times what it's supposed to be because the baby's having to try to push against that high pressure and then getting regurgitation back as well on the right side from the left side. So hypoplastic left, the prognosis may be poor. You can do these procedures after delivery. The latest thing now on the horizon, and there's actually a couple protocols, and they're still mulling this over. Actually, I had a baby who had hypoplastic right heart we sent to Boston. And what they did was at about 28 weeks, they put a catheter in the baby just like they would cath you for cardiac. Ran the catheter up, very small catheter up on the right side of the heart, the tricuspid valve, and ballooned it open. Like a balloonoplasty, just like you're doing a balloon on an adult or other normal person. Valvuloplasty, if you will. The baby did very, very well, brought back, had great flow. Then it got bad again, went back and had a repeat procedure, which actually stayed open pretty well. I think that kid's about 7 or 8 now, and as far as I know, he's not had a follow-up cardiac procedure, but the left side is a similar idea. If you can open the heart up to get it to grow, because the fetal heart will not grow as well after delivery. You have to sort of treat it in utero, otherwise the hearts just don't seem to grow and keep up and become an adult heart, and sometimes end up as heart transplant people, even in spite of all the procedures you do on the heart, the different kind of things you do. All right, now I'm going to switch gears a little bit. Okay, take a deep breath. Boy, that Calhoun talks fast. Yeah. Sorry. Yes.
All these slides that you're showing, are they all from ultrasounds? Or
Yeah.
you can get all that information from ultrasound?
Yes. For the most part. I mean, some of it you have to do like amnio, like for some of the infectious stuff, you kind of have to, you can tell it might be due to certain things, but yeah, some of it you have to do amniocentesis with. But all the other stuff, the structural, yeah, I can see it all in ultrasound. And most of it I can see relatively early. 14, 16, 18 weeks. When I'm doing my anatomy, I can see all these things pretty much. And now with my new Cadillacs, as I call them, or Mercedes machines, it's just unbelievable now. Yeah, I mean, they're just the bomb. Yes, ma'am.
What about pain? Like when we have surgery, we get
Right.
medication for days after.
Right.
What happens?
Were you talking about in utero?
Yes.
Well, usually, like realistically, if you sedate mom, that does help, and you do sometimes paralyze the baby so you can do things. But realistically, we understand there's going to be pain, but if you don't treat, they're going to die. So my response is you can't really sedate mom to the point of unconsciousness to treat the fetal pain. We know they do feel pain because they withdraw, they grimace, they do all those things. And they actually do provide fetal pain medication for the operative procedures when they treat them. They give them pain medication to keep the baby sedated because we know that they do better if you treat them. Just like you treat newborns with pain medication, they do better. So there is some of that. It's a little primitive because we really don't have a lot of good information on the neurological effects inside or in utero, but we can tell by the way they act, there is pain there. And we do sedate moms, so that does help, I think, because it does cross. Yeah, good question. Now we're going to switch gears just a little bit. We're going to talk a little bit about, how are we doing? About 20 minutes, we good? Yeah. And talk about trisomy 21 and a couple other things, because I think there's some very interesting things on the horizon with that. That's my good friend, not the guy in the front. That's one of the, I can't remember what congressman that is, I'm blanking. But it doesn't matter anyway, right? They all look alike. I'm just kidding. That's Dr. McCaffrey, one of my good friends, a captain of the high seas with his wife. And this is Claire. Claire has trisomy 21. And because of that, Dr. McCaffrey is actually a neonatologist. So he and I are sort of partners. I do the prenatal and he does the postnatal. So a lot of this stuff is stuff he's shared with me or talked about on some of this. The trisomy 21 stuff is very interesting, which is stuff I did. Then we're going to talk a little bit about some other trisomies. So basically, if you look at phenotype and genotype, genotype is what your underlying genetics. The phenotype is what characterizes your disease. That's what you are on the outside, quote unquote, even though people seem to be having trouble with that nowadays, deciding what they are, but really, yeah, anyway. I'm sorry, is my microphone on? So what we do is we look at animal studies and try to look at neurobiology and neurophysiology and try to figure out if something that works in animals or works in another area, will that help us work? And we look at drug development, we look at pharmacokinetics, how they work, and then we try to do trials in animals, then we try to do human trials to hopefully give us the information we need for human development. So if you look at, I'm not going to go through all this, but if you look at Down syndrome, there is a reduction in the size of both the fetal and adult brain. There's also cholinergic neurons that have been altered. There are deficiencies in speech and articulation, all these things. There's alterations in the brain because of Down syndrome or trisomy 21. That's the first thing. Neuronal differentiation is different. Myelination is different. All these things are a little bit different. So, ultrasound findings that you can see in Down syndrome that I see are there's a smaller cerebellum and there's a decreased size in the frontal lobes. Okay? And you can see the bossing of the front of the head and smaller baby head as early as 15 or 16 weeks. And you see a growth in both the front and the posterior portion of the brain. So what we find histologically when people who Down syndrome we've done autopsies on is that there's decrease of neurons in certain areas of the brain, and cerebral volumes actually decrease as well. There's also impairment of the way cells repair themselves and do things and proliferate and repair, right, and grow. So there's alterations in both the things that carry your signals and the things that actually submit or transmit those signals, your dendrites and your neurons, right? So what we also know is that it's a function of how they interact is how the brain works, correct? So depending on how they are all put together will tell you how you can actually either long-term or short-term store, right? If you connect properly, you can connect and get these together. Just like if alcohol impairs the way in which your frontal lobe interacts with your hippocampal area, and so you get these frontal releases, right? More people are more loquacious and entertaining, so they think, and all these and memory impairments, right? Long-term, short-term. So that's all in the same areas of the brain. We know that these GABA receptors, which are affected by alcohol as well, is a primary inhibitory transmitter. So there's all these different classifications, but you see slow and increasing inhibitory responses based on what happens, and when you change those, you change your ability to have memory and or learn. That's what you need to understand. These receptors are critical to learning. Down syndrome is thought to exhibit an excitatory and inhibitory imbalance. In other words, the receptors are not quite right. So certain ones are being excited improperly, certain ones are being inhibited improperly, so memory and learning are impaired. Okay, just like alcohol does or drugs do, very similar to that. So the alteration impacts your ability to do these things, and then there's also neuronal death because the receptors are not being processed properly. So you get differences in transmission, and then you get early cell death and inability to repair, right? And so this very high loss rate may also cause the increased risk of seizures and other things you see in Down syndrome. We also know that this regulation causes all sorts of other things, and cell death is increased, and all these things may cause the delay in learning and all the things that we see in Down syndrome related to receptors. So we know that. Oops, wrong way. Going the wrong way here. Okay, so looking at a Down syndrome mouse model, which is very interesting, right? I prefer lawyers, but mice are... There's something that even mice won't do. Yeah. I'm sorry, I hope there's no lawyers. Did I offend somebody? If we look at non-competitive antagonists of the GABA receptor in these medications, and we lose at non-competitive agonists of the NMDA receptors, which are a couple medications, both these therapies showed improvement in a Down syndrome model in mouse cognition. Yeah, just treating them with these medications, right? Very interesting. What they said is if you looked at these fragments of the factors that were being treated by the medications, they all improved in the Down syndrome mice. They also found they had improvement in their learning, essentially, without toxicity. And they also found that SSRIs, which are the medications used for depression, right, serotonin reuptake inhibitors, like a GABA inhibitor, did not seem to work in the mouse model. So, smaller brain, cerebellar hyperplasia, midbrain issues, and neurogenesis, and all these things that happen. The genes are crucial for this, and they're crucial for all this cognition, right? So what maybe might happen is if we look at some other things and we look at those and try to say, is there a template for us helping this? I'm not going to go through all this in detail. It's boring for you. There's different things: autism, tuberous sclerosis, neurofibromatosis. So what we found is if we do these new GABA-A inverse agonists, they may improve, if you treat mom with them, improve the outcome for the Down syndrome baby. Now, those are in phase 2 and 3 trials at this point. So, and there is some evidence to support, if you do this, I've had some personal communication with some people I know, say this actually does seem to work and improve. It improves cognition, decreases seizures, and delays the onset of which a lot of Down's children and a lot of adults have, is early onset dementia and sort of things that go along with the deterioration of the brain in the Down syndrome person. So there's more on the, so even though we said, oh, we can't treat Down syndrome, maybe we can. Maybe it's just we haven't figured out and thought through what's the issue. If it's a receptor issue, it is amenable to treatment. If it's a receptor issue based on what you have in utero, we can treat that because we can prevent the degeneration and actually enhance the development of the myelination in the dendritic system and decrease the amount of brain maldevelopment if we treat with these medications. So stay tuned on that. More out there coming down, I'm sure. Although you can't do it in Iceland. I'm sorry. That's why we're not buying Greenland, okay? I'm just kidding. So what about trisomy 18 and 13? So Down syndrome, I think we're going to see therapies for that. I really, truly do. I really, truly do. Because it models just like a lot of other, dementias and all the different things with Alzheimer's. It's very similar. The things, changes you see are very, very similar. What about trisomy 18 and 13? I'll try to finish here. So these are trisomy 13 and 18 babies. These are the ones, the pictures you're always showed in your textbooks. These are the pictures they always show the moms and dads when they want to counsel them. Oh, look, here's your monster baby. Look at this. It's all, blah, blah, blah. Yeah. That's non-directive counseling, by the way. Yeah. So what is the history of trisomy 18? If you look at the survival rate about the first year, even though they say it's lethal, it's not lethal. Because if you look at over here, about 31% of these babies are still alive in trisomy 18 at 1 year. So it's not fatal, right? It's not lethal, right? And even through 2 to 3 years, there's still 17 to 20% are still actually doing okay at 2 and 3 and 4 years of age, okay? So keep that in the back of your brain. Trisomy 13, very similar, 1 year, a little bit lower, but still 10% or more are alive at over a year or two, all right? So it's not lethal, okay? It's not lethal. So numbers, about 25, 30%, maybe trisomy 18, 10 or 15% trisomy 13. Just hang your hat on that for just a minute. Put that in the back of your brain. This is not showing up the way I would like to do. So at 1 year, we talked about that, about 15 to 20%. Trisomy 18 is a little bit higher, about 15 to 20% or 25%. At 28 days to 5 years, still 15 to 20% or more of these infants are still alive. Now, so we have had an individual here who's born prematurely, but many years ago, and is a miracle of survival, right? How many babies who are 23 and 24 weeks survive to discharge without severe morbidity? According to this study in 2015, it's probably a little bit better than that. About 20%. Now, what does that sound like? Sounds scarily like trisomy 18, doesn't it? And 13. So let's see. 10, 15, 20%, 10, 15, 20%. So I'm going to resuscitate the 23-weeker, but the 13 and 18s, not so much, right? Okay. So I'm just saying. Just saying. In West Virginia, I'm just saying. What about those of us who are a little more mature? And we look at survival rates for selected cancers in England and Wales, which is over there in our good friends across the pond. Your lung cancer and pancreas survival is 21 to 30%, 5 and 10 year survival. For selected cancers in lung and pancreas and esophagus, 5 to 10%. But generally offer therapy to people with pancreatic cancer generally, right? I mean, even if it's stage 3 or 4, they usually do get something. But their survival rates are that. So, if you're going to treat something that has a survival rate of 5 or 10%, are you going to treat something that has a survival rate of 15 to 25 or 30%? Again, I'm just saying. So, if you look at trisomy 13 and 18 and 21, it's clearly being discriminated against based on your genetics, right? You're clearly being discriminated against based on your genetics, your genotype, not your phenotype, because phenotypically you're not really different than a 23 or 24 weeker if you look at outcomes. Or you look at outcomes treating the various, high-risk cancers, particularly pancreatic cancer and the lung cancers. So it's not a matter of, can we treat? It's a matter of will we treat and should we treat? And we need to stop telling people this hopeless thing that your child with trisomy 21, we can't do anything, right? Your child with trisomy 13 and 18, we can't do anything. That's simply not true. There's lots of things we can do if we would choose to do so. And the families who have children with special needs generally don't see themselves as being put upon or having had a problem with a child who's born to them has special needs. It's the doctors and other people that have the problem, right? The handicap's in their mind, pretty much. At least that's my experience, but what do I know, right? Well, I'm going to sort of give you the teaser for the later lecture. So what do we do with terminally ill neonates? We do hospice. And we're going to talk a lot about that later. And I always tell people we should demonstrate compassion and not abandonment. Again, we're just supposed to foster hope, not hopelessness. Things that were not treated 25 or 30 years ago, we now treat routinely. We did not treat 30 years ago neural tube defects. We now treat them routinely in utero. We did not treat hypoplastic hearts. We now are able to treat those. We did not treat other things like twin-twin transfusion. We now treat them very routinely. These are all because of fetal therapy. So all these hopeless cases are not hopeless. They're always hopeless if you don't do anything. assuredly, if you don't intervene and give anybody therapy, they die. That's not really hard to do, right? That's not hard to figure that out, but they die. So I just want to let you know that it's not really hopeless. It's not hopeless. We just have to think about it a different way. We start to have to develop ways in which we can actually treat and make these things better. Any questions? Yes.
To address cerebral palsy because that is one of the top 5, I would say, diagnoses that women are counseled to abort.
Cerebral palsy?
Right. Can those be treated in utero?
At this point, the problem with cerebral palsy is we don't know what causes it. I mean, most cerebral palsy is without an etiology. I mean, we know that's related to prematurity and to some other things with acute fetal acidosis, if you will, but that's pretty rare. Most cerebral palsy, we have no idea why it happens. It just appears basically out of nowhere. And it's very difficult you can't really diagnose it in utero. You can sort of say, maybe this child might be at risk with some sort of a brain anomaly, but it's very interesting, all the stuff I see in terms of intracranial anomalies, how very few of those kids are actually affected, because kids are plastic, they just overcome it. So it's very difficult to do that. And I never recommend that anyway. I mean, you don't know till the child's out and you get a chance to see what's going to happen. You really don't. People think they're godlike, but they're not. Yes, ma'am.
I was Rh negative and I had my daughter, and then they gave me a shot.
Right.
I did not understand what they were doing. They said they're stopping the antibodies from rejecting my possible second child.
Right.
So,
I didn't go into a lot of detail. Now, because of what you just explained, Rh disease is virtually gone. You now give a person an Rh immune globulin, which is the antibody to protect against the blood from your child at 28 weeks and after delivery. What it does is it binds up their red cells and prevents it from sensitizing you so you don't get the Rh disease. It works very, very well.
yes,
Yeah.
because I had my second child, no problem.
Yeah, rarely see it anymore. Very uncommon for Rh disease. Yes.
I've heard this a number of times. I'm sure people in the room here have too. Some mothers told that they're going to have these great defects and their child's not going to walk, talk, and the child is born and does phenomenal. What's happening there?
Well, what's
Just-
happening there. It's called, you don't know what you're talking about mostly. I mean, really. No, I mean, really, you look at an ultrasound, you're looking at shades of black and white and gray. You are not looking at a baby sitting in front of you. You are not looking at a diagnosis, quote unquote. You're only seeing some images which do not tell you anything functionally about that child. That's why it's very dangerous for a doctor to say, well, I know, blah, blah, blah. No, you really don't. The anencephalics are probably one of the few that you know that child, if it has anencephaly, is going to die shortly after birth, some way, shape, form, or time. That's one of the few times you can say that. Everything else, realistically, you're depending on stuff you might have read, but may or may not be true. Like you said, trisomy 13, 18, we're all told medical school is fatal. It's not fatal. That's just misinformation. You don't know what anybody's going to do. I've seen babies born with half a brain and they became politicians. No, I'm just kidding. Just kidding. Seriously, you see all sorts of things in medicine where people have all sorts of things you find and they actually totally functionally normal. I mean, really, truly. You see CT scans, people are missing literally a whole hemisphere. They're missing the integrated corpus callosum. They have all sorts of interesting things going on and they're just fine. So you really can't tell that by looking, again, you're looking at black and white shades of gray on an ultrasound. And even with a diagnosis of trisomy 21, there's differences in levels of trisomy 21. It depends on early interventions. It depends on treatment. It depends on all the things you do and how you care for people, just like everything else. You just can't predict these things like people want to say. You can give them information to prepare them to be aware to intervene and do more interventions on their children and help them prepare for that and to help them get the help they need. But you can't really say how somebody's going to turn out. You just can't do that. That's just impossible, really. I mean, it really is very interesting. People say things all the time, and I just look and go, I don't know where you're coming up with that. That's. Somebody else had another question? I'm sorry. Yeah.
What is neuroblastoma?
Neuroblastoma is a large tumor in the head, usually, or neurofibromatosis is the multiple little fibers, little tumors all over you, and you get stuff inside your head as well as the skin tumors.
Does that begin in the
It can, yeah, it's genetic, so yeah, it is. It can be, you can actually see the tumors and stuff inside the head and stuff, yeah, occasionally, yeah. Sir?
First off, Monday night,
I think it's variable wherever you go. I mean, certainly my students get this because I teach them all this stuff all the time, but I think it's variable, and that's part of the problem, is that, you know, you've got people teaching different things instead of saying what's really out there and what's available. And it advances very rapidly, too. Are we? Yes?
We all know that a boy has an XY chromosome and girls have two X chromosomes. My question is, I read a study and it suggested that there's more autism with boys because something in the vaccines might be triggering an effect on the X chromosome. So the girl has one to fall back on, but the boy doesn't. So that's one question. The second question was all the estrogen and other pharmaceuticals in the water. Could that possibly be a cause of all this gender dysphoria that we're seeing?
Well, the vaccine thing is pretty difficult. My reading of the literature, I'll tell you what my reading of the literature says, it really doesn't seem to be affected by the vaccines. I really think it's alcohol and drugs is my personal and other things going on. And the reason I say that is because nobody was testing for all that stuff until about 5 years, 6 years ago, maybe even 10 years ago. So now that we know that 15% of the population in general, everywhere, is using illicit medications and drugs, methamphetamines, cocaine, benzodiazepines, opiates, and THC. Of course, THC is natural, right? Yeah, it's like a vegetable. So I really think that's the issue for the autism issue. I really truly think that. That's just my own sort of reading of all the stuff. I've been doing this a while. The gender dysphoria stuff, that I have no idea about. I can't answer that. That's something I've not even looked at really. I mean, I understand all that stuff, but I'm not sure whether that's it or not. But we do know there's been effects on fertility rates and other things with the huge amounts of estrogen in the water table affecting the environment in terms of fish and other animals. We do know that. That's out there. So it certainly could be possible, actually.
Just clarify, Brian, you meant drugs and alcohol years before the baby was in vitro?
No. Well, while they're conceiving and while they're pregnant. My patients, okay, for instance, my patients have a 35 to 40% incidence of substances, illicits. And none of them say they use it, of course. Because nobody does drugs, right? Yeah, no. Yeah. Right. So that's why everybody gets screened. So we did our anonymous study a few years before that, 15% overall in the state of West Virginia, which is about the national average. Some subpopulations like mine are higher. So I really, truly think, and the tobacco abuse that's gone on, are really the issue. They're really, truly, because women didn't used to do these things, right? Because before, they wanted to be moms, they didn't smoke, they didn't drink, they didn't do drugs. And this is all before, you wouldn't get, before moms were going to be moms and women got pregnant and had babies, and there was all this, we talked a lot about contraception yesterday. All that stuff was going on. Now that that's all, the genie's out of the box, that all goes by the wayside. Because it's really all about you now. It doesn't really matter about the baby, right? Yeah.
Is it known whether early intervention after a baby with Down syndrome is born, does early intervention actually make a lot of difference in their ability to learn and whatnot?
Oh, absolutely huge. I mean, if you look at the birth to 3 data and you look at early intervention data on any child with any sort of delay or developmental issue, it doesn't even have to be Downs. It could be cerebral palsy. It could be anything you see. The earlier you intervene, the more you get that child with the parents to learn how to adapt to learning for that child and teach them how to do things, the much better they do. And that's clear. I mean, that data has been out there for years. And it's all children who have any sort of an issue, or anybody for that matter, who has anything that they need, any therapies or interventions for learning or anything like that. It really makes a huge difference. Because children are very flexible. They're plastic. They can be molded in lots of different ways and helped in a lot of different ways. They really can. Yes.
Okay, so if the mother doesn't take drugs or anything, but the dad does, he's smoking, whatever.
Yeah.
Doesn't that affect the baby too?
Well, it can, because you get secondhand smoke and other things. So if they're smoking in the home and bringing that stuff in, yeah, that can be the case. Although it's not so much genetic, we don't think. It's more, it may be. There's some.
Isn't the sperm affected by what he's doing?
That's always the question, and there's some data that supports that may be an issue actually if fathers are doing drugs and other stuff. It's not as strong as the association with moms, obviously, but there is some data out there that kind of says that might be the case as well. Yeah. Yeah. No zero-sum game, right? All right. We done, right? Thank you. We're done. Thank you.